This is It's Not In Your Head podcast with Dan and Juz. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. Okay, you're only doing this because you were late, Dan. Were you twirling your hair this time?
I wasn't late. I wasn't late. I was cheating.
Oh,
so here's the deal. So no intros today. Juz reckons that we are better when we just riff.
We just roll.
Where we just roll with it. So
you were right. My headphones were not fully plugged in. That was
there,
the
I told you.
I selected that. We were both right. I selected the right button. I just didn't plug them in all the way.
So we are straight into it on Q&A.
More Ask Us Anything.
And so, yeah, Ask Us Anything.
Very creatively named.
Kinda.
Better than Q&A.
Okay, yeah. Go. So what was the question? What was question number
What are we talking about?
One?
Yeah, so these ones are a little bit more medical veering. So the first one we're going to cover today, and this is near and dear to my heart. What is the difference? And we can both kind of give our 2 cents towards this. What's the difference between full body CRPS and central sensitization, which is an awesome question because they go together and overlap so much. Dan, do you want to start?
Okay. So CRPS is a set of specific diagnostic criteria called the Budapest criteria.
Woo, Hungary. Woo, woo. Does the audience know I'm half Hungarian?
They do now. Don't tell the American government.
But we're not far behind.
It's true. You got nowhere to go.
I have anyway. Well, technically I do, but yeah, essentially. Not with my own heritage. All
right. Okay. So Budapest criteria, surprise, surprise, were developed in Budapest. One of my friends was actually at the conference that they did. So yes. Alan Burton, shout out to Alan, who's actually now the chief medical officer for Abbott Neuromodulation. So he's a lovely guy.
Ties in perfectly with our next question.
Yeah, no, actually, yeah, there's a ton of neuromod stuff we'll talk about today. So Budapest criteria, set of criteria. The interesting thing, talking to Alan was really interesting because I didn't know this. The reason why I got set down was for insurance purposes. So they, at the time, CRPS, and this terrible pain syndrome was recognized as a problem, but it didn't have any diagnostic criteria. So tons of stuff was just getting labeled as complex regional pain syndrome. And so to sort of sort things out and go, this is CRPS, this is not CRPS, they laid down a set of criteria around it. And so those criteria include you've got to have ongoing pain post a event. So, and that pain is disproportionate. Right. So that kind of fits with our whole central sensitization piece in that it's disproportionate pain. But you've got to have other symptoms to it as well. So you've got to have hyperesthesia, or allodynia. So allodynia is pain on light touch, and hyperesthesia is essentially increased symptoms in response to a normal sensory input. So excessive touch, excessive vibration, excessive whatever, pick a sensation. You get vasomotor. So vasomotor are vascular changes, and they include changes in temperature and changes in skin color. And then you get the next piece within that, and they kind of go together in my head, which are called pseudomotor, which is basically increase in swelling in an area. And then the last piece is you get motor changes. So what that means is you can get cramping and different. Yep. And I have an interesting chap at the moment who's, although I've seen him recently to manage his pain is normally reasonably well controlled, but he's got terrible contractures from the CRPS. The other thing that takes place with CRPS within that setting is that you can get tremor, and then you can get what are called trophic changes. Trophic changes is essentially your hand, arm, leg, whatever gets skinny. Right. And so you see these sort of changes. And so
do the changes to nails, like nail and skin, fall under the trophic changes too?
Yeah, I think they do.
Yeah.
So yeah, hair, nail, skin sort of fall into that as well. So coming back to that concept, the question, whole body CRPS. So whole body CRPS is then this, from the diagnostic criteria, widespread disproportionate pain with allodynia, which is pain on light touch, plus
all those
variable
things.
amounts of weird ass swelling, muscle stiffness, contractures, tremor, and vascular changes. So you're getting changes in skin color and abnormal
everywhere.
sweating and all that stuff. I've got to admit, I've never seen, maybe it's seen me, but I haven't seen it. I've never seen all over complex regional pain syndrome. I've seen complex regional pain syndrome in entire legs. I've seen complex regional pain syndrome on half bodies, like left side of the body, CRPS, right side, tickety boo.
Yep.
I have a patient like that at the moment. But whole body, I would say I haven't seen. But, if you look into all those symptoms, like they fall into the central sensitization buckets. So you've got hypersensitivity. So you've got hypersensitivity across pain when it's widespread. We label you with fibro. I think we've got a fibro question coming. So widespread, it can be regional, and then you get disproportionate symptoms like hypersensitivity to light, sound, smell, touch, taste, heat, cold, balance problems, food disorder. So I think that that's how central sensitization overlaps with the sensory hypersensitivity piece. Where it also then overlaps is within the dysautonomia symptoms. So with the dysautonomia symptoms, if you bucket them within central sensitization, you get abnormal sweating. So that's where you're getting your hot flushes and disproportionate sweating. You get your POTS type symptoms or your orthostatic intolerance, so lightheadedness and dizziness when you're standing up. You're getting your gastrointestinal symptoms, so your IBS type stuff, then your bladder symptoms, so you're getting labeled with bladder pain syndrome, etc. In that setting. So I think that the thing that's different with CRPS is that those symptoms are focal. Like from my perspective, what you'll normally see is you'll see a hand or a foot or something where someone just gets weird swelling, redness in a hand, or abnormal sweating in specific areas. I think that with central sensitization, you tend to see it more broadly. So people are just like got all over the body night sweats and stuff along those lines. So
and even CRPS, if it's in an arm or in a leg or in two legs plus a lower, like what you'll get is the spread of the sensory sensitization, like Stan's saying. And because you have an increase in neuropathic type of symptoms. And so that piece of CRPS is what is felt then in more than that, typically one or two limbs. And full body CRPS would come along with every one of those criteria in all of the limbs, rather than a few of the symptoms, particularly those sensitivity related ones, being the ones that become very widespread. And that's where patients get this fear of spread and overwhelming spread of aspects of CRPS. And it then becomes very scary when you think you have and feel like you have spread, but it's actually the spread, so to speak, of central sensitization as that gets greater and greater. And then it becomes a more muddied picture. And those autonomic symptoms are then what get often labeled as internal CRPS, but they're actually aspects of central sensitization. And the CRPS again is separate, but there's those overlapping components.
Yep.
Cool.
Next one.
All right. Ooh, this is a good one.
Here we go.
I'm gonna get my 2 cents on this one. All right. Do you recommend spinal cord stimulators, especially for CRPS patients?
Okay. Let's go with a bunch of disclosures first.
Asterisk.
Asterisk. Okay. From here on, don't pay attention to anything that I say. So why? So I do.
But this is good. It's like the good, the bad, and the ugly.
This is what you got to understand. So
yeah.
I do use neuromodulation as a technique to treat neuropathic pain. I have used it for CRPS for a number of patients. I am a consultant to Medtronic, although in Australia we're not putting any Medtronics at the moment. That's a whole other world of discussion. What else? I do put in devices across most companies at the moment. They include Nevro, Boston, Medtronic. Well, not Medtronic at the moment, but I've got a number of patients have them in. Abbott and Saluda. Now, my bias at the moment is Saluda. So I've got an interest bias, and I think that they're probably the best on the market at the moment for a number of reasons. What else is my biases in this? I do have some options in a company called Nalu, which you can't use in Australia. So, because it's not registered here, so it doesn't make any difference to my practice. Also doesn't make any difference to my bank account either. So anyway, okay, that's all I got. So if you want to not listen to what I say, they're all the reasons not to listen. But I'll tell you, I'll give you my 2 cents on this. So I'll give you my take on Neuromod for CRPS, and then you can give me yours because you've got one for CRPS.
Yeah.
So
we got one that implants them and one that lives with them.
Yeah. Neuromod is a technique that treats a component of the pain. It doesn't treat all the pain. And I think that that's where you've got to start if you're going to think about it. And so and I suppose maybe a step back, what's neuromodulation? Okay, so neuromodulation is where we use electricity in the form of some little wires. We place them either next to nerves out in your arms and limbs. We place them next to nerve roots, which is where all the nerves coalesce before they enter into the spinal cord. So that's called the dorsal root ganglion, DRG stim, and that's important within the discussion of CRPS.
And with different stimulator types too, the classic versus a DRG stimulator.
And then you've got spinal cord stimulation, which is where we place leads on the inside part of the spinal canal, and you basically get them to buzz, and through various mechanisms, they essentially inhibit the sensation going from the periphery up to your brain, and then they down-regulate the pain. So
yeah, leg to brain, brain to leg, that pathway for
pretty
me
much
is where there's boop.
So fundamentally, do I recommend neuromodulation for CRPS? Yes. That gives you just a straight answer. There's a couple of like about a bazillion provisos in that. Okay. And so one of those provisos is to recognize it only treats part of the pain. So the best study we have for this was done, it's called the Accurate study. It's a comparison between dorsal root ganglion stimulation, where you put leads over the nerve roots, and then, which is what Juz has, and she'll go into that in a tick. And then it has, and it compared then standard spinal cord stimulation to where we place the leads over the spinal cord. And so what that study showed is that with dorsal root ganglion stimulation, 70% of patients gained a 50% decrease in their pain. And when with spinal cord stimulation, 50% of patients got a 50% decrease in pain. Okay. And so, and that, I think the original data on that was 12 months. I can't remember whether they published their 2-year data.
Well, and that's more and better
they've
data
gone on
CRPS specific than other treatments even.
Yeah,
because that's the challenge with CRPS is it's so rare that there's not that many good
and
studies
so
on
that's the largest and best randomized control trial that's been done. I think that what we all want to reflect on within those results are 70% of patients got 50% pain relief. That's not 70% of patients
got 80
were pain free.
Although, when you're living with such extreme pain, 50% is a humongous difference.
You go from an 8 to a 4. That goes from distressed, unable to do anything to, continued.
You can imagine a life
functional,
sort of, worth living and go from there.
Yes. So number one, it's incomplete pain relief for most people, but it's in the setting where you've done everything else.
And so is that also, Dan, because it's addressing that neuropathic piece of pain in particular,
Yeah.
in comparison to, as we talked about in the last question, those widespread sensory issues, the other aspects of central sensitization that depend. So
Interestingly, with DRG stim, a lot of that stuff goes away as well. Like, it's
you see
amazing.
it.
Yeah, you can see like
It takes time
one,
also.
like I got some great pictures of patients where,
Yeah,
one
how they drew
bright
it.
red foot, one white foot that's
Right.
normal, and you treat the DRG and they're like both feet look normal. Like
Right. The
that
local part.
symptomatic, yeah, that sympathetic component of your pain like
Right.
improves as well. So it's not, and that's in part because the dorsal root ganglia contains like tons of different types of nerves. It's got sensory nerve, it's got motor nerves, it's got components,
Yeah.
sympathetic components to
Right. So
it.
it's touching on various aspects at
So
least,
yeah,
but
so you are stimming everything, which is why it makes
in that.
sense to do it for CRPS, particularly
Yeah.
focal CRPS, and
Right.
and in that setting, that's what it's real. I think that's what it's
Well,
on label. Its on label use for is actually like focal neuropathic pain.
which can target a certain area
Yeah,
better. Like you can't put in 4 leads in someone who does have more genuinely widespread CRPS. It increases the risk of
yeah,
all the complications that can happen. So yeah, smaller
yeah.
spot, easier to target.
The other thing in it should be in a multidisciplinary environment. Okay. So, and what does that mean? That means, it doesn't fix the psych stuff. Do you feel
Well,
better? Yes, because stuff hurts less.
right.
And that can fix a lot of the psych stuff for people. But people that have got pre-existing anxiety and depression, that still needs to be dealt with.
And trauma, which is a huge piece of for whatever,
Yeah.
reason, it
So
is a
all the
large piece.
losses, you got to be able to deal with it. You need Yes, you need to be able to, you do continue a certain amount of medications. And certainly, we have a process at the moment where once we put somebody onto a stim, then we start working through this process of, okay, now we're going to bring you down off the opioids. We've got to,
Right. Now you
titrate
can
down this,
decrease
titrate
other
down this.
things.
And then
Yeah.
as you are titrating those things down, it changes how sensitive your spinal cord is. So you then got to change the stim again.
Right.
So you're sort of like decrease drugs, change the stim, decrease drugs, change the stim.
Yeah.
So we sort of work through that. But you still have ongoing medication involvement.
Right.
You're deconditioning after having had long-term like neuropathic
CRPS.
pain
Right.
is like significant.
Massive.
So you got to
right.
like, so
You still have to do all
like
the lifestyle
stim,
stuff
is it
and
going
the
to like
movement
give you
stuff.
tons of guns? You have to go and lift
Oh,
something.
I wish there was a stim for that. Yeah. Right.
So you got to then involve that. So it is a tool within a multidisciplinary approach to be able to go through. And I think that
right.
where we have fallen down within the neuromod world is that we've missed the multidisciplinary stuff post.
Right.
Because you know what, the guys that put in stims, like myself, like we're good at sticking in it. We're good at using needles, and we're good at putting in stims. We're not as good as the whole of the broad weighing stuff. And I think we've fallen down in that setting. Now, I'm sort of glad that I have more support around that these days. We do a better job, but you'd have to look at the stim world and go, guys, we've got to get better at doing that.
Well, that's why I do what I do, right? What the spinal cord stimulator does is it opens the door and it allows you to begin to have a chance at working on those things. Because when you're in such extreme pain, you can't. I mean, it's I couldn't put my foot on the ground basically for the first year and a half. And a lot of the other drivers of pain that we talk about too, and the other amplifiers of pain from a lifestyle perspective and a metabolic perspective and a compensation perspective have nothing to do with the stimulator. So that's where that 50% pain relief is huge, but it's still only 50% pain relief. And, me too, even post-stim was like although I'm way, way better, it's still really hard to imagine the rest of my life like this. And you have to start
on the 50% piece. What I just want to highlight is that we're talking about CRPS in this setting. Other types of neuropathic pain, so post-surgical neuropathic pain and stuff, respond better than CRPS. And so we are now getting to a point at which we're getting 80 to 100% pain relief in increasing numbers of people. So that's really been the shift. So where before we had this target of 50% pain relief in, greater than 50% of people, now we're aiming 80% pain relief in 80% of people. That's what we're going for. And so whenever I'm doing particularly a trial, and maybe we'll come back to this sort of question, but a trial is where you test the neuromodulation first before putting in the battery.
Right.
I personally will be looking for an 80% decrease in somebody's pain. So, if you can have a trial or a test where you get 80% decrease in your pain, and what we see is patients are sleeping better.
Right.
They get to go out to dinner.
Do a little more.
They go for a walk with their partner. They sleep better. Okay, that's a positive trial. I had a 50% decrease in my pain, but I didn't change my medications. I still couldn't sleep. I still feel terrible. I didn't get to do anything else. That's less of a, and this is where I wanted to lead into. Then you've got to say, okay, we've got 50% pain relief, but now you've got the downsides of managing a battery. You've got a bunch of leads, and that comes with downsides. So, Jazz, let's lead into the downsides of STIM, because there are downsides.
Yeah, I mean, and to be fair to STIM, it's just like any other medication or treatment decision. It's just a big one. It's, do the upsides outweigh the downsides? Yes. And that calculation will also be different at different points of your disease course. So although there's downsides too, a lot of people, even me too, when you think about, am I going to do this surgery? It's like, well, I'm going to have a battery forever. Well, first of all, not necessarily. This can also be a tool that you use for a few years to a degree of time to get you to a better place. You earn yourself some freedom and you're able to make a new decision of, like in my case, for example, at this point with this level of symptoms, would I even implant the battery? Probably not. So I am one of those people who, because I'm kind of an outlier, right? Implants aren't as often put in younger, leaner people who are trying to be more active. Even before I had the implant put in, I was doing CrossFit, like on one leg, doing Olympic lifting like an insane person in my garage, which I would,
you were such a badass.
In hindsight, not
what was I doing? I got CRPS, but I'm going to start CrossFit.
Oh my God. It was because I could only stay in one area. I could barely stand for more than 20 minutes and I couldn't cover any ground. And it was during COVID when there was I had no access to a gym.
I'm just going to say that all of those things are like irrelevant. You're still a badass.
Thank you. I was very desperate. It was very confusing because then your doctors are like, but you're doing CrossFit. You must be doing great. And I'm like, you don't understand. Like, I'm not. And so for me, I had exhausted other things. I didn't want to go down the million medication route the same way I had over the brain injury years. So I got to STIM relatively quick, about a year and a half into the disease course. The challenge, other than the obvious risk of complications for me, and that's what everybody's scared of, the leads are going to break, the wire is going to break, et cetera, are the compensation patterns that develop. In particular, the leaner you are, the more active you are, and probably based upon where it's implanted, location-wise. And also, to be fair, if you're more prone to stuff like that happening because of underlying conditions, like with my pelvic instability and ligament laxity due to hypermobility, that sort of set the stage for the battery in me causing more issues from my pain perspective than maybe somebody else. Or if you have more fatty tissue in the area where it's not, causing such obvious sensory differences. And so the downside is the other types of pain, body part pain, basically, that you can develop learning to inadvertently or on purpose work around the stimulator. So you can become very protective of it, right? It's a $150,000 device. You don't want to break it. Everyone's like, keep your spine in neutral. Well, actually,
50?
Yeah.
Jeez.
Well, not out of pocket, I think, but I mean, yeah.
On you guys?
Yeah.
Bro.
No, not out of pocket.
They're paying in the US?
Yeah.
Okay.
Yeah.
We're not paying that in Australia. Thank goodness.
Yeah. And the peripheral ones are like 30. I think so.
So a stim is to put it into a context, most stims.
Is it conversion rate?
Yeah, well, in the Australian dollar range, you're probably looking at 30 to 40,000, up to 45 in Australian dollars, after you've gone through the process of trial implant,
permanent. Yeah. And so from a sensory perspective, scars, weight gain, weight loss, surgeries, hypermobility, the way you sense touch on your skin, and a battery, putting a piece of metal under your skin does change the way that you perceive and feel, and then thus recruit muscles in that area. So that's one of the difficulties that I have had to deal with living with it. And that's one of those things that's not very well discussed. It's not very well articulated. It is a bit more of an outlier, and it's not studied. Like, this isn't something that there's a whole bunch of large scale studies around. And again, to be fair, the upside downside of where I was at with how excruciating my CRPS symptoms were compared to terrible back pain, I would have made the same decision. It's just unfortunate that in my case, it has contributed to back pain that over the years has become more intrusive than my CRPS leg. But that's because it did its job with my leg, and it's not the only thing contributing to my back pain.
Yeah.
Right.
And
so that's where it's hard.
I think it's interesting. Like, so I learned this from you because of
something good that came out of it. Yeah.
So one of the things, and because I saw this in another patient, in that similar to you, similar age,
right,
hypermobile, and they had a fusion at L5S1 following a big disc protrusion, and they had significant nerve root like compression, which causes an injury, and then she had ongoing pain afterwards. And so So we managed the neuropathic pain with the neuromodulator, which worked great.
Crushed it. Right?
Yeah, crushed it. But what was not apparent at the time was the degree of underlying pelvic instability that she had due to her hypermobility.
Prior to the stimulator, also from shifting weight, you're literally having one leg off the ground. So it wasn't like, oh my God, back pain out of nowhere because of.
And I think that what had happened for her is that we put the stim in, we ended up having to move its position. But once we moved the position down over to buttock, I think what happened is what's happened for you, which the stim itself has inhibited her glute muscle function.
Right.
So your glutes in part stabilize the sacroiliac joint. If you've already got loose ligaments, then you're really reliant on them, and you put the battery there. And look, and to be honest, I only recognize this because of like talking to you and go, oh, that's what's going on for you. So it's not common that I see it, but yeah, so that like as a secondary issue, sure. Right. I think it's something that we've had to go in. And I think that this discussion is something of there are other issues that go along with the stem.
Right.
The good thing about the stems is you can pull them out.
Right. That's
you can't pull out a fusion.
Right.
You can't and if you get better, you can pull it out.
Exactly. And so that's kind of where I'm at, is testing, turning it off and seeing, can I live without it?
And that's an interesting thing with CRPS, because CRPS, it's as a disease process, it will resolve over time in a reasonable number of patients. It's not 100%, but a reasonable number.
There's kind of that 1 year mark, fear and interest, where it's, if it doesn't improve at least some before a year-ish, it becomes more unlikely that it just resolves completely. But it can continually improve. And that's the whole thing with, relentless forward progress, is you stretch time out. Like where you are, me 5-6 years into it, is not where I was 3 years into it. It's way, way worlds different than where I was at 1.5 years into it. So you cannot imagine when you're at those earlier points where you might be a few years down the line. And even if it takes you 5 or 6 years, you do earn yourself freedom and different decisions that you can then make.
And I think
all the lifestyle stuff and the psych stuff, and work on those other pieces that are the other 50% too. And then you're dealing with a different picture.
And if you come back to that point you just made then, which was over 12 months, it becomes less likely that it completely resolves, which means diagnose it before 12 months and
yes, please,
treat it.
This is the whole issue that drives me nuts.
And so it's a question. I think there's something in here about when do you stick in a stem or something like that. Anyway,
not
the
first.
average period of time, if you look at the research, the average period of time that somebody gets a stem after having their pain is 14 years.
Right. It's the last house on the block. I've done everything. Situation.
I think that if you look at the what's called the NICE guidelines, which is the UK guidelines, their guidelines are if you have neuropathic pain that remains intrusive, that has been non-responsive to all other therapies at 6 months, neuromodulation is inappropriate. And so I certainly, now that becomes a very, you get
It's
into
an
it.
interesting conversation because do you get it early to shut it down early, but are you doing it so early that it's that it's too early for the
interesting.
stim?
Yeah. So
Yeah.
that gets interesting. So what sort of neuromodulation? So you get at that 6 month mark, and so I rarely put in a device that you would treat like before 6 months. Like,
would you do more of a peripheral, like a less invasive option in those cases, Dan?
not necessarily.
Doesn't okay.
No.
That's really interesting.
And although there are risks to putting in a stim, so and those risks, so let's be open and all about them. Those risks are spinal cord injury, so which is as rare as hen's teeth, but it has occurred. And spinal cord injury then includes, paralysis. It includes, loss of sexual function, loss of bladder function, et cetera, but it is a rare event. The spinal cord sits in a sac. If you put a hole in the sac, it leaks. That's called a dural puncture. That'll give you a headache. It will generally go away. So if it doesn't go away, you do a blood patch and that will take it away. I've had 3 over 10 years, which, and recent, one of them was recent actually. And what I actually did is I managed that with a blood patch in theatre because I was pretty confident.
Oh, immediately.
Yeah, I did it immediately. Yeah. And she woke up the next day with no headache. And I was like,
that's interesting. Yeah.
Go down. But I was confident that I'd unfortunately given it a dural puncture. So it was a good outcome.
Confident in the mistake. That's good.
Yeah.
Okay. It's going to happen. Yeah.
And then other things that you get with this is there's a risk of spinal cord hematoma, which is where you have a bleed on the inside part of the spinal canal. Once again, rare as hen's teeth. I've not actually seen it ever with neuromodulation, but it is reported. There's the risk of infections. Epidural abscesses are bad. I haven't had one, but one of my colleagues has had one. We managed that with antibiotics and that got better. And the patient went on to then have a implant after that and did really well. Other problems are IPG site pain, and there's a question about that a little bit further down.
Pocket pain, basically.
Pocket pain, and the pocket is where you place the battery into. And then the other risks are the leads can move. You fall over.
The device itself malfunctioning or breaking, which is actually what happened to me. Is I have 2 leads placed and one of them fractured, and it's not even because I have no idea why. I didn't even fall or do something weird in the gym, or oh man, that really hurt all of a sudden. And that's what led to my fork in the road of could I live without this now that I'm only getting half the therapy anyway.
Yeah.
So, but I went years, 2.5.
We'll come back to lead migration within DRG in a moment, but lead migration within spinal cord stim, basically the leads effectively just sit there, right? We suture them or anchor them into place down outside the spinal canal, just underneath your skin, and they kind of just sit there. And in 10 years, if we go to pull them out, you just undo the scar and they just slide out. Like they don't scar into the space or anything along those lines. And so if you fall over and you like yank on everything, you can move those leads a lot. And these leads are targeting specific areas and specific nerves on the spine. And if it moves out of the area that it can, that it's buzzing over, you have to reposition them. And that's just the way. And so that is a real risk. That is something that I probably reposition leads maybe twice a year at the moment. So it's not common. And at the moment I'm not doing tons of stims at the moment, but I'm probably doing 2 to 3 a month at the moment, which is not much at all compared to a number of my colleagues. No, it forms a part of my practice. It's not anywhere near all of my practice. That covers kind of the majority of complications. There have been issues with DRG leads fracturing more. The DRG leads are like 0.8 of a millimeter across. Like they are tiny. They might even less. I can't remember. So they're very, very fine leads so that they are more predisposed to fracture. And when we say fracture, what that actually means is the leads don't break in half themselves. They've got this
Right.
silicon or whatever on the outside of them. But there's little contacts at the end, and they'll either be, depending on which company you're working with, 4 for DRG leads, 8 most commonly, 12 with Saluda, and then after that, I think 16 for some of Boston's leads. And each one of those little contacts, you can make buzz between each other. And then what takes place is that there is a lead. There's a little wire inside the lead that's about 1 millimeter across that goes all the way down, and then you then plug that into the battery. And so when you get a lead fracture, what's actually happening is that one of the little wires, or 2 or 3, or, you know, I've never seen all of them go, not for a long time,
Some
not
of
for
them
not for 10 years.
Yeah, and even around them if you
outside
can,
of
right?
outside of DRG leads. Like DRG leads are a little bit more temperamental.
Yeah.
And DRG leads have been, because of the way we were implanting them, so it was a technique thing, they were more prone to moving. We have now, the technique to implant them has now changed due to some work from some guys out of New York who've done an amazing job. So Kieran Patel and I'm forgetting his name. I'm so sorry, dude.
But you
It'll
too.
come back to me. Anyway, I've done a wonderful amount of work to improve the technique. And so now we have a better technique, better anchoring. Lead migration is much, much less. Lead fracture is much, much less. And so, yeah, we got better at it.
Which is
so there you go.
Yep.
But when they move, they're annoying, specifically DRG leads. They're hard to put back in.
Yeah, you get another surgery. That's the pain of it.
Interestingly, DRG lead do create a certain amount of scarring in the epidural space. And so they are much harder to put back in than spinal cord leads. Spinal cord leads, if they frack, pull them out, put them back in, no big deal.
Because it's so much closer to the surface. With DRG leads, Dan, if someone decides to, bag the device, do you leave the leads in, or would you would you try, even though they're more scarred open?
No, they'll come out.
Out?
Yeah, okay, no, they'll still come.
Okay.
No, it's not so much. They're not more difficult to get out. They are more difficult to
put back in.
To put back in.
Yep.
Yeah.
Okay.
So, but no, you pull out all the leads, and the reason why you do that is around MRI compatibility, etc. So if you were just to leave the leads, they're not MRI compatible. And so that's the other problem with neuromod.
Yeah, the other pain.
Different neuromodulators are variably MRI compatible. So let's not dive into the technicalities.
Yeah.
Basically, if you're going to get an MRI, you can MRI some things and not others. You have to have a shorter period of time, and you have to turn and
special MRI itself.
Yeah.
I couldn't even get one at UCSD, which is a massive hospital system.
Yeah. So that'll be because they've got a 3T scanner, and the DRG only, are they approved? I can't remember. I'm speaking out of turn, but I'm pretty sure they have 1.5T, which is when we say T, it means Tesla, not Elon, like the original
not to be
dude.
Confused with, yeah.
Not to mention, not the car, the dude, like the original dude. And it's just basically a lower strength of magnet.
Yeah.
So, which is interesting. And apparently in the US, there's quite a number of 1.5T MRIs still around. In Melbourne, there's bugger all. There's...
Really?
Yeah, because in Australia, we have a 10-year limit on medical devices for which we continue to fund.
Just got some bunch of old-ass MRI machines.
So you got to turn them over. So you turn them over and think. Anyway.
Okay.
So stims, they're good for decreasing pain. They don't do everything. It's part of a multidisciplinary approach.
It's a good tool.
And they are part of the toolkit. They are not the toolkit.
Perfect.
All right.
Let's go straight into, so I'll just ask the question, because since this is essentially what we were talking about. Will back pain due to SCS wires ever get better? In this case, for this person, removing them is not an option. And in fact, this is one of my patients. Shout out to one of my favorites. She actually lives with 2 batteries, which is a lot of action. So there's a lot of other issues and underlying issues going on in this patient's case also, and it's a combination of challenges that are leading to back pain, including sensitization in the area, inhibition, underlying HEDS. I would probably venture in her case wasting of the muscle, maybe multifidus wise itself as well. So right, there's a lot of things that are creating pain, but for the component, for the purpose of this question, that is more attributed to the wires. Dan, take it away, or close to the pocket at least.
Okay, so what do you do about, so what we're talking about here is you're talking about you get hypersensitivity over the wires, or hypersensitivity, particularly to touch, over the battery. Okay, and so we refer to that as pocket pain. You see it in approximately 30% of patients, and you can add that. So pocket pain, you see it in about 30% of patients. It is intrusive. Most people rate it about a 4 out of 10-ish on average.
And I know some people that can't charge their batteries because of it, unless so they actually becomes an issue with placing, if you have that type of stimulator, that on top of the battery itself, which is a problem.
Maybe we should talk about different types of batteries.
Yeah, we'll do a stimulator like episode.
Because some are chargeable, some are non-rechargeable.
Mine does not require charging. Yeah.
Some have got peripheral battery. Anyway.
We'll do it. It's a good episode.
So this is, for me, it's a focal problem. And I don't know, you can explain it in multiple different ways. I just explain it to patients as, you've got a nervous system that doesn't like you, and we put some stuff into you and it makes it hurt more. So, and it's pissed. So how do we turn that off? So I have done so much stuff to try and get this under control. So I've used local anesthetic patches. We've used topical and anti-neuropathic. Creams with amitriptyline,
the neuropathic pain algorithm,
pull all that stuff out. And when all that hadn't worked, we would go, okay, we'll move the battery. And so you go in, you pull the battery. Sometimes you have to take the entire system out. You have to put the entire system back in, and you move it to a different site, and you keep your fingers crossed that they don't get the same problem somewhere else. So we're in anecdotal world now. So I'm just going to put out, I'm going to give you my solution, but this comes with the proviso that everybody understands that this is currently anecdotal. I haven't published this data. I'm starting to collect it. So
deep breath.
Because this solution sounds batshit crazy.
It's low risk. Like, this is when you hear what it is.
So, But a couple of years ago, a colleague of mine had said he was treating somebody for pocket pain with platelet-rich plasma. So platelet-rich plasma is where you take blood, spin it down, separates into 3 layers. Middle layer is platelets and white cells, and you then collect that and inject it into whatever you're trying to inject. And I thought, that doesn't really make a bunch of sense to me, but I'll give it a crack because I've got nothing else. And PRP is very safe. Like, it will block it. The likelihood you get an infection out of it's super low.
Slim to none.
Because there's a lot of white cells in it, and it kills bugs. So I thought, all right, I'll give it a crack. So I give it a crack, doesn't work. I went, okay, I didn't think it was going to work. So, but what it brought me to was a thought process where back in about 2010, there was a New Zealand guy called John Liftoff.
A great name.
Yeah, no, it's not how you say it. It's spelled Lifgoyf. I don't know, something like that. But it's named. It's said Liftoff. He's pronounced it Liftoff. Anyway, so John had published a study on tendinopathy, and what he had done is he'd used ever decreasing concentration of glucose. So in this setting, we refer to this as prolotherapy. And he basically had tested higher concentrations of glucose and got it down to 5% glucose, which he found was the most effective and the lowest concentration of glucose.
Okay, so you're trying to find minimum effective dose of
that's what he did. And for anybody who's had a tendon problem, and he did this mainly for Achilles tendons, when you touch the tendon, when you grab it, it's hypersensitive, like it really, really hurts. Yeah. Like it's jump off the bed stuff.
So CRPS.
Yeah. Well, but not CRPS.
Not CRPS.
Not CRPS.
It's intense.
hypersensitivity. So it's mechanical hyperalgesia here. So CRPS gives you allodynia, which is pain on light touch.
Yeah.
Mechanical hyperalgesia is when you push on something or you squeeze something, and that produces disproportionate pain. It's different receptors.
Yeah.
So he got on and published this, and he'd shown that you could decrease the hypersensitivity with 5% glucose. And so back in 2010, I'd used this in trigger points. It settles down trigger points, which are sort of areas of muscle, one better term, tightness, and areas of hypersensitivity. But at the time, like, there's such little data on it. It felt like voodoo medicine. It still feels like voodoo medicine. But I acknowledged that it did actually work. But it just felt like too much voodoo medicine, so I ditched it. And I stopped using it. I hadn't used it for years until PRP suggestion, pocket pain. I thought, I wonder what's causing this. I wonder if this is the same thing. And so at that point in time, they had hypothesized that it was acting on a receptor called TRPV1. So TRPV1 is responsible for mechanical hyperalgesia and burning type pain. And they'd gone on, and since then, they had gone on to do a set of studies. This is one of my favorite studies, where you torture a bunch of med students. And what they did is they put capsaicin.
Finally, not the mice. Finally.
So capsaicin is chili powder and cream. They put capsaicin on their lips. So it's like burning. So your lips are burning.
Dan, in high school, there was this lip gloss that was really popular called Venom. And it was like this cinnamon burny. It had this, I swear, probably had a little capsaicin in it. And it would cause a little plumping of the lips.
All right. So they torture the med students, and they put the capsaicin on their lips. And then they used a cream that was a combination of 5% glucose and mannitol. And they were able to turn off the burning sensation. And so the hypothesis came from there that the 5% glucose and possibly the mannitol in that setting were having an effect on TRPV1 receptors, because we know that capsaicin triggers off TRPV1 receptors. I went, okay.
Logical.
I then went and had a look at the research, and ever since 2010, there's been a ton of data done and bucket loads of randomized controlled trials on 5% glucose. It's called 5% dextrose in carpal tunnel syndrome. So carpal tunnel syndrome is a syndrome where you get entrapment of a nerve in your wrist, and it creates a bunch of symptoms into your hands. And those symptoms are generally common in the morning. You wake up with them, hands, numbness, tingling, pain, etc. Yeah. And so these studies have done excellent randomized controlled trials of injection of 5% glucose around the nerve that gets entrapped. They were able to show that they had decrease in pain from that, decrease in swelling of the nerve. And there's been so many randomized controlled trials on this. So it's kind of
just not for pocket pain itself, but for other applications of it. And you just
super safe, tons. So many trials that it's now in Harrison's textbook of medicine as this is one of the things you can do for carpal tunnel syndrome. I'm like,
let's do.
Okay, wow. So we've gone from it being voodoo medicine to it actually being medicine.
Accepted.
Yeah. Although it's nowhere near accepted, but it's just at least
known.
It's less voodoo. So I started to try. So I thought I'm going to give it a crack on IPG side pain. And so what you do is you identify the patient's area pain and sort of like
palpate.
Like you push on it, and they say, "I'll push on it. I'll push on it. I'll." And what you generally find around a battery is there'll actually be focal area that's not the entire area. And then you inject subcutaneously 5% glucose into that area. It follows a very reliable pattern. So if it's going to work, the pain goes away at the time. It's immediate. It's like, it's bizarre. It works so well. And it's like, okay, this voodoo has worked for you. And there's no local anesthetic in it. It's just the 5%. And so people will then go away. It will last 3 days to start with, and then it wears off. We then do it again. Patients generally will get 4 or 5 days out of it. It then comes back. You then do it the third time and it tends to settle. Why does it follow that pattern? I don't know.
That's
The
so
pattern
interesting.
is
Super
very
super short term, long
and the
term.
long, yeah.
That is really.
And so, but the pattern is very reliable. We're sort of collecting data on it at the moment, sort of match that out. And so what we will do is we'll give patients a pain chart that they'll go away with, they fill out, and we basically watch their patterns. If they're
So you
following
almost
the
look at it like a
pattern,
series then instead of
so
a
I do a series
single,
of injections. And so that's my go-to at the moment. Now, is it a permanent solution? The answer is no, because chronic pain patients' nervous systems don't like them. So it tends to come back, but it is like it'll be further down the track and you can treat it again.
Yeah.
And it settles. So it's become my treatment option. There's technique issues within it. Like it's weird. If I was in, like, you can't see my hand at the moment if you're listening to us, but if you can, and you were doing a technique where you sort of inject along one finger, next finger, next finger, next finger, if you don't get in between the fingers, there's still pain in that area. Like why does it do that? I don't know. You've got to get like the fingers and in between the fingers to get all the pain. Like there's some other theories on how it works. The TRPV1 receptor mechanism makes sense to me because it works so rapidly. Like there's other mechanisms where they argue that you've got increased supply of glucose to the nerve is then functioning better and then it decreases pain. I just don't see how that's a thing for it to work so quickly. And if it doesn't work on the day, then it's not the problem.
Right.
Go on to
if it
something
doesn't work
else.
Immediately.
Yeah.
It's not the problem.
And I've gone on to, there's some other things that I've tried with pocket site pain that, once again, we're getting into anecdotal world because there's not much data on it. So anyway, it's a hard problem.
But that's a good sort of simple, straightforward solution, at least, which is nice with
simple
problems.
Yeah.
Relatively harmless, low risk, not a big complication.
Yeah. Really low risk and cheap. Like 5% glucose. I think like to do the injection, I think like I just ask patients to pay an extra $20 to cover the cost. The 5% glucose, the bags are like $7 or something. So once you add in some needles and some blah and some blah,
it's like a bag of candies. Yeah.
So there you go. So not that expensive, safe. And if it's going to work.
Right. You get immediate feedback.
Because if pain doesn't go away when you put it in,
biased.
Then don't do it. Don't continue.
Well, and it's not this, did 50% of your pain go away? It's just, it worked or it didn't work.
It is.
It's clear as day.
It's stand up. My pain is gone.
Great. Nice.
It's good. I've got a couple of magic tricks. That's one of my magic tricks.
Told you, Dan gets a little witchy.
All right, let's go with one more question and wrap it up because you've got like the wiggles going on.
I'm into standing mode. Yeah. I sang the national anthem at our MLB Padres game last night. Not me alone. Don't get excited. Me and my chorus, but it was quite an event. So I'm a little gassed, but bring it home here. So
good work.
Thank you. Yeah. Doing new things, doing more.
We should talk about getting out and doing stuff that you want to do, particularly with your.
It's like travel.
Recent.
Spree. No, but like that expanding boundaries and doing stuff you're scared to and borderline is not a good decision. But you're like, you know what? If I can get myself to do this and then recover and then it's worth it. Did the upside outweigh the downside? Yeah. And being able to do more is the point of everything we're talking about, right? Like the stimulator, et cetera, et cetera. It's to be able to live more life. So it does.
I'm not going to ask this question now. I'm going to do that as I'm going to make
Dan's adding a question.
I'm going to add a question to next time. They'll get you to talk about that.
Dan, submit it to my inbox.
And you can
email from Dan.
I will. I'm putting in a question. And I'm going to ask for photos.
Oh my God, I have many. I will send them. I do.
All right,
I have proof. I have to have evidence. All right. Back to CRPS a little bit. This has been
a skewed one
for me. Okay, with CRPS. This is actually pretty straightforward, so it won't be as long as the others. With CRPS, veins sometimes bulge dramatically or recede. I see this all the time in patients and obviously experience it myself too. Is this circulatory, the recession part in particular, and what causes that?
Do you want me to go?
Yeah, I mean, my answer would be the same as yours as far as edema. And that's, extreme swelling in the local area, at least for when veins recede more and more. And they just kind of become this little like spidery looking situation rather than when you look down and you can normally see your veins. I also think, how much do you think the sort of vasomotor contributes to that, and the
So it's a vascular component. So it's a
right,
sympathetic component of CRPS. So
of that pathology.
CRPS. So in that setting, when you've got the sympathetic nervous system involved, your sympathetic nervous system controls your vascular system. So it has a role in dilating blood vessels. It has a role in making seeing how leaky they are. So when they become increasingly leaky, that results in your swelling taking place.
It's like downstream vascular driven by the sympathetic.
Yeah,
not vascular
perfect.
On its own.
So that fits into your color change. It fits into your intermittent swelling,
red,
which fits into the diagnostic criteria of thing. Now, one of the things that I think that is useful that you can take out of it is that it means you do have a sympathetic component to your pain, which means that says, oh, maybe you can address the sympathetic nervous system. And so that's where you can start thinking about like blocks. So injections. So for your lower limbs, you are targeting around the L3 level.
Yeah.
For your
upper
limbs,
sympathetic lumbar injections.
So sympathetic lumbar injections. So that'll get your lower limbs. For your upper limbs, if you're aiming at shoulders, you do stellate ganglion blocks, so which is C6. If you're looking at entire upper limbs or periphery, you're looking at T2 sympathetic ganglion blocks. And, and then after that, you can kick off with some local anesthetic and some cortisone. And if it's good, you can then go on and do like pulsed radio frequency of that area. So pulsed radio frequency, you're creating an electrical field in the area. And that electrical field then alters nerve function, and so triggers off the release of anti-inflammatory factors from the nerve itself. Interestingly, in the US, there's not much pulsed RF that gets done.
Yeah, it's weird. I don't know why that is.
It's not funded.
We did talk about this. Yeah.
So there's no item number for it.
Which sucks if you're a CRPS patient, because the burning nerves is not really awesome necessarily, and so then you don't have a less aggravating
I don't know. I think that interestingly the data is increasing on pulsed radio frequency. We've started doing more of it. Like, it works. It's got a really low side effect profile. Like, you can repeat it. Patient gets like increasingly incrementally better. Like, we had previously like poo-pooed it because of its lack of data, and we thought it was rubbish. I would like to say we were probably wrong. And so we are also collecting our data on that at the moment. So we're hopefully we'll put out some papers on that later in the year. And the other thing it does is it opens up from a medication perspective. You can start thinking about medications like clonidine. Clonidine may be more effective in people who've got sympathetic components. And interestingly, there's data that suggests that if you're responsive to a sympathetic ganglion block, particularly L3s, you might be more responsive to ketamine infusions. And so, that can be like a stepwise process. So you have an L3, that was good. Okay, good. Now let's maybe think about a ketamine infusion, see if that also works, et cetera, et cetera. So each one of these things gives you a hint of, what's the next most likely or what might work more effectively next.
Is there one that correlates with STEM, Dan, better, similarly to the ketamine, like sympathetic lumbar? That worked well?
No. With STEM, the way you work it out is you do a test, like you do a trial of the therapy first
itself.
And you basically see, does this improve your pain enough that you're willing going forward with the, with the battery side of things. You know what? I still do a reasonable amount of STEM, not tons, but enough. And I like it. Like, it changes patients' lives.
It's right procedure in the right person at the right time, hits it out of the park. Wrong procedure, procedure, not ideal person, wrong time, not so great.
There you
necessarily.
Go. All right, let's wrap it up because
cool.
Giles needs to wrap it up. and there we go. So
and we did get through our questions for this episode. So
great.
Aside from my wiggles.
And there you go. No prep.
See?
Maybe that was
so
better.
Natural.
I don't know. People will tell us.
This is us off the cuff. We'll see. Yeah, you can get cat's coming. All right. Yeah, Bean says we're done too.
Okay.
Okay.
Cool.
Well, as always, if you guys have any questions that you would like to submit, you can either send them to our Instagram or our email. The email is dan@juz@iniyh.com. Instagram is iniyh podcast. And Dan's going to submit his question to me directly. So be ready for next time.
All right, I'll get onto that.
We don't know about episode order, so I won't get into what is next, but we'll continue delving into and expanding upon the metabolic pain piece of things and release these type of Ask Us Anything questions just periodically throughout the season as we go.
Cool. All right.
Cool.
Thanks, Charles.
Thanks, Dan.
See ya.
See ya.
Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not a consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.